Welcome to This Explainer. Today, we're going to unpack the structural collapse and, honestly, the necessary rebuilding of African health financing. This isn't just a story about spreadsheets and numbers. It's a deeply human story about political economy. It's about a massive system essentially running on fumes, and what happens when a 25-year donor scaffolding is just suddenly pulled away. Okay, let's start by grounding ourselves in the real human stakes here. Picture this. We're in a primary healthcare center in Bauchi State, in northern Nigeria. In the waiting room, there are 14 pregnant and nursing women. But the clinic has completely run out of basic anti-malarial medicine, what's known as SP, which is absolutely crucial for preventing maternal anemia and low birth weight. Some of these women walked up to 8 kilometers just to get there, only to be turned away completely empty-handed. Now, what's really wild, and frankly terrifying, is how normalized this has become. As the head nurse pointed out, this was already the third stockout in a single quarter. This wasn't some freak one-off supply chain glitch. It's a symptom of a systemic structural failure. We all know what stockouts do to mortality curves, but the real question we have to ask ourselves is, how exactly did this system get here? That brings us to Section 1, the arithmetic of survival. Seriously, how does a health system serving 1.3 billion people reach a point where basic preventative medicine is treated like a luxury? For anyone following global development or health security, this is the defining question of the moment. Because a fracture in health systems on this continent, well, that impacts global stability and economic futures everywhere. To really understand it, we have to rewind to a promise that was meant to change everything. Right. So in 2001, in the Nigerian capital, African leaders made this landmark commitment called the Abuja Declaration. They set a negotiated target to allocate at least 15% of their annual government budgets to health. It was supposed to be the foundational floor of public health. But here is the harsh reality check. 25 years later, depending on how you run the numbers, only a tiny handful of countries, like literally between 2 and 4 out of 54, have ever managed to sustain that target. $16. Think about that for a second. In 2020, most African countries were spending anywhere from $237 down to as little as $16 per person, per year. $16 to deliver primary care, maternal care, immunizations, and chronic care, all combined. It's just an impossible task. It's an arithmetic trap. And, there's this persistent myth out there that if everyone just miraculously met that 15% Abuja target, everything would be fixed. But the math is incredibly stark. Even if every African country perfectly hit their pledge today, based on their current GDPs, they'd only reach about $37.50 per person. Compare that to Europe's $2,600 per capita. The Abuja target wasn't too ambitious. Mathematically speaking, it was way too modest. The fiscal envelope simply does not work. Let's move on to Section 2, 3 structural traps. So if the budget envelope is obviously too small, why don't governments just allocate more money? Well, enter trap number 1, visibility asymmetry. Finance ministers are operating on super tight budgets and short electoral cycles. They easily get political credit for, say, cutting ribbons on flashy new highways. But health investments deliver really diffuse returns, like a reduction in child mortality 15 years down the line. You can't exactly cut a red ribbon on a life that wasn't lost, right? Because of this, health ministries almost always arrive at budget negotiations structurally disadvantaged. Then there's trap number 2, donor displacement. Over the last 2 decades, we saw this extraordinary mobilization of foreign aid step in to fight specific diseases. By 2022, it grew to account for 31% of all health spending in low-income countries. But here's the quiet little bargain that happened behind the scenes. When external donors stepped up to fund massive HIV, malaria, and immunization programs, domestic governments kind of used that as an excuse to shrink their own health space. As the donor door opened wide, the domestic door quietly closed. And finally, the most devastating trap of them all, the debt vice. The African continent collectively spends over $81 billion annually just servicing external debt. Compare that to the $145 billion spent on all health, domestic and external combined. In 2023, sub-Saharan Africa literally spent more on debt interest payments than on education. Finance ministers are being squeezed in a massive vice, forced to prioritize international bondholders over their own domestic public health. This perfectly sets up Section 3, the 2025 funding shock. Okay, with all those systemic traps set, the sand foundation this entire system was built on just washed away at a dizzying speed. On January 20th, 2025, a new U.S. executive order froze all foreign aid. Just 4 days later, on January 24th, PEPFAR, the massive HIV relief program, was specifically named in the freeze. And by February 26th, roughly 90% of global projects administered by USAID under PEPFAR were simply terminated. In a matter of weeks, the global health financing architecture fundamentally collapsed. The fallout? Immediate and absolutely staggering. Just look at South Africa alone. $420 million were instantly wiped out from the national HIV response. Over 8,000 skilled healthcare jobs were lost within weeks, and clinics just had to close their doors. The forward-looking projections are terrifying. Across the continent, models suggest this collapse could cause up to 10 million excess HIV infections and millions of additional deaths over the next decade. This essentially created a brutal, real-time, natural experiment in how different nations react to a crisis. South Africa bent but didn't entirely break. Why? Because they had slowly built up to covering 74% of their national HIV response domestically. Ethiopia, on the other hand, had to scramble overnight. They literally had to introduce a brand new emergency payroll tax to urgently substitute those lost USAID funds just to buy HIV medications. It proved a really painful point. Aid dependence is a development trap. Which brings us to our final part, Section 4, Rebuilding Health Sovereignty. Look, the illusion that foreign donors are going to fund African public health forever, that's completely shattered now. The future cannot look like the past. Rebuilding this system relies on 4 very specific pillars. First, serious domestic taxation to build reliable internal revenue. Second, risk pooling and health insurance, which is vital to stop poor families from paying out of pocket when they are most vulnerable. Third, and this is absolutely critical, fighting for major debt architecture reform on the global stage. And fourth, empowering strong regional institutions, like scaling up the Africa CDC and producing vaccines and medicines locally. Just to give you a sense of the sheer potential here, $50 to $90 billion. That is the estimated amount lost annually to illicit financial flows out of Africa, often through things like multinational corporate tax evasion. That amount is roughly 2/3 of what the entire continent spends on health each year. Recovering even a fraction of that money would entirely change the continent's health arithmetic. It would create a budget envelope that doesn't depend on the whims of foreign capitals that might withdraw their support at any second. So, as we wrap up this explainer, we're left with a pretty massive question for all of us. Are we going to keep trying to patch up a broken, vertical, donor-dependent system? Or will we finally put our weight behind this new model, walking toward the harder but much brighter light of true health sovereignty? Let's keep those 14 women in the bocce waiting room in our minds as we navigate this new reality. The era of deferring this problem is over. The only question now is who is going to step up and build what comes next.